Greetings. Welcome, welcome to our esteemed worldwide audience. I'm Dr. Eleanor Nwadinobi. I'm the immediate past president of the Medical Women's International Association, a global association of female medical practitioners. We are also a pioneer partner of the Global Sepsis Alliance. I am deeply honored to be your moderator for this 15th and last session, but certainly not the least, of the sessions of the 2026 World Sepsis Congress. The theme for this session, protecting women and children in health emergencies and humanitarian crises. Sepsis is responsible for 1 in every 5 deaths worldwide, affecting nearly 50 million people each year. We would like to hear from you and for this session to be as interactive as possible. Before we start our sessions, allow me to share a few housekeeping points. We would love your questions. And you can use the function in the controls panel at the bottom of your screen. We have invited 3 speakers who will talk us through each key part of this session. And we will end with closing remarks from Niranjan Kissoon, the Global Sepsis Alliance president. So let's kick off with Afrah Thabet, who will be speaking to us today on addressing maternal and newborn sepsis in Yemen. Afrah joined UNFPA's Yemen country office as far back as 2005. She holds a medical doctorate in obstetrics and gynecology, and she currently continues supporting the Yemen country office UNFPA as the sexual and reproductive health specialist. Over to you, Afrah. Afrah, you may be on mute. Are you able to unmute? We'll give you a few minutes, Afrah. These technical hitches do happen from time to time. If I may, we'll give you some time to sort out those technical issues, Afrah. And while that's happening, I will go on to our next speaker and then come back to you. All right? So permit me to now introduce Yamikani Chimwaza to speak to us today on advancing maternal sepsis diagnosis in Malawi, evidence from clinical research. Yami is a maternal health clinician scientist and implementation researcher based in Malawi, with over a decade of experience strengthening antenatal and emergency obstetric care in sub-Saharan Africa. Yami also holds a PhD in women's health, global maternal health, and is a leading researcher in maternal sepsis diagnosis, focusing on early warning systems for obstetrics, prognostic blood biomarkers, and diagnostic accuracy in low-resource settings. Yami, the floor is yours.
Thank you so much, Eleanor. Good morning, good afternoon, and good evening, everybody. It is my pleasure and my honor to be presenting at this year's World Sepsis Congress. As Eleanor said, I'll be presenting on advancing maternal sepsis diagnosis in Malawi, and I'll be sharing some evidence from clinical research. So as we've been hearing over the past 2 days, maternal sepsis remains both a major burden and a preventable tragedy. The WHO defines maternal sepsis as life-threatening organ dysfunction due to infection. Globally, it accounts for approximately 11% of maternal deaths. In low and middle-income countries, it rises to up to 50% of in-hospital maternal deaths. And in Malawi, where the maternal mortality ratio is at about 224 for 100,000 live births, sepsis contributes about 25% of maternal deaths. So it's safe to say maternal sepsis is clearly common, it's severe, and importantly, it's preventable. In Malawi, it is now the leading cause of maternal mortality, surpassing postpartum hemorrhage and eclampsia. And the women most affected are often young, married, established mothers, many living with HIV. This highlights both the clinical urgency and the equity dimension of this problem. So why is diagnosis so difficult? First, sepsis is not a single disease. It's a heterogeneous syndrome with diverse causes and outcomes. In maternal health, this complexity increases because there is no universal consensus on maternal sepsis diagnosis definitions, and there's no clear agreement on how to define organ dysfunction in pregnancy. Currently, we rely on the sepsis 3 criteria, which is infection plus organ dysfunction, defined by a SOFA score greater than or equal to 2. However, this score was developed in the general adult population, and it relies on parameters that are often difficult to measure in low-resource settings. We should also consider the physiological changes of pregnancy, where increased heart rate, low blood pressure, and increased respiratory rate are normal. But these changes mimic sepsis, making it difficult to distinguish normal from pathological. In addition, sepsis scores are poorly validated in obstetric populations, and biomarker evidence largely comes from non-pregnant populations. The risk is high for under-recognition and delayed diagnosis, and this leads us to a key conclusion that diagnosis cannot rely on a single test. It must be context-specific and multi-layered. So to better understand this, we developed a conceptual framework that we used in Malawi, and we focused on 2 key areas. Firstly, the patient journey, recognizing that delays across this journey contribute to adverse outcomes. We examined delays in seeking, reaching, and receiving care. And importantly, for the first time in Malawi, we looked at delays in the post-sepsis period. We used a multi-framework approach incorporating the delays model, the WHO quality of care framework, and the respectful maternity care domains. Secondly, along the process of diagnosis, we examined how early warning systems and biomarkers could strengthen diagnosis within this pathway. Our patient journey data provided important insights that across the continuum of care, the most significant delays occur at the facility level, that is the 3rd delay. There were not only structural issues that we observed, but also communication failures, inadequate monitoring, and workforce constraints. So each delay represents a failure in the diagnostic process. This reinforces that diagnosis is not simply a technical task, it is fundamentally a systems-level process. We then examined early warning systems using global data, and we found that among 21 early warning systems, obstetric-specific scores performed better than general scores. Some scores were effective for ruling out sepsis, others were better for ruling in sepsis. However, none achieved optimal performance. Most scores fell in the mediocre range, limiting their clinical usefulness. This tells us that no single test is sufficient. Instead, early warning systems should be used as first-line screening tools within a broader diagnostic pathway. We also evaluated biomarkers in Malawi among 254 women with suspected infections. We assessed procalcitonin, interleukin-6, serum amyloid A, and C-reactive protein. Although these findings need further validation, it did show that procalcitonin performed best, improving sensitivity when combined with vital signs. Interleukin-6 and serum amyloid A were sensitive, but they lacked specificity. And C-reactive protein showed poor discrimination. Importantly, no biomarker achieved sufficient accuracy on its own. So the takeaway message is biomarkers are useful as adjuncts and not standalone diagnostics. They improve detection, but at the cost of increased false positives. This brings us to the most important evidence for our local setting. The sepsis trial demonstrated how diagnostics can effectively be embedded within an integrated, multi-component intervention. The study successfully combined a structured early warning system within a targeted sepsis treatment cascade, alongside antibiotic prophylaxis and improved hand hygiene practices. And together, these components work synergistically to reduce severe sepsis-related maternal outcomes. The sepsis trial demonstrated a 32% reduction in severe maternal outcomes. Critically, this improvement was not driven by new diagnostics. It was achieved through routine vital sign monitoring, standardized charts, clear escalation thresholds, and structured response protocols. In other words, diagnosis improved through systems strengthening. Because the intervention linked recognition to action, it reduced delays, and it standardized decision-making. It transformed diagnosis from passive recognition to active, timely response. So when we compare settings, the contrast is clear that the diagnostic approach to maternal sepsis differs in high-income settings, where there are advanced diagnostics such as bedside lactate point-of-care tests, multiple biomarkers can be tested in a panel, and more comprehensive ICU care. And this is all algorithm-driven care. In Malawi and other resource settings, we're faced with limited lab access, greater reliance on clinical judgment, and significant system constraints. So the gap is not knowledge, the gap is implementation capacity. Therefore, an optimal approach combines clinical recognition, such as the use of early warning scores and vital signs. It incorporates sepsis biomarkers, and it has a supportive health system. This forms a multi-layered diagnostic strategy. So to summarize, maternal sepsis is complex, it's time-sensitive, and the strongest evidence in our setting supports system-based interventions and not new tests alone. Biomarkers remain promising, but insufficient in isolation. Moving forward for low-resource settings like Malawi, we need to validate combined clinical and biomarker algorithms. We need to develop point-of-care diagnostics, and we need to adapt pregnancy-specific thresholds. We also need to strengthen our health systems. So I'll end with this key message. Advancing maternal sepsis diagnosis in Malawi and low-resource settings requires integration and not innovation alone. It's about strengthening systems, it's about using appropriate clinical tools, it's about integrating biomarkers, all working together. Because ultimately, if we can fix the pathway, we can fix the diagnosis. I'd like to thank all the sponsors and all the funders and all teams in Malawi, in Liverpool, and Birmingham. Thank you.
Thank you very much indeed, Yami, for sharing the Malawi experience and the essentials in low and middle income countries. I'm looking in the chat to see if we have any questions, but whilst our audience are preparing their questions, I would be interested in knowing to what extent you feel that there are possibilities for replicability of what you have done in Malawi in other low and middle income countries.
Well, I think I can start with the patient journey mapping exercise that we did. Unfortunately, that was under academic research and was a very laborious exercise. I think what needs to be done in other settings is reinforcing patient feedback mechanisms. The patient journey was the one-on-one interaction with patients, which would be very difficult to replicate across all the patients and, every woman being discharged from hospital. But I think if we can find easy to use feedback mechanisms that even, lay people can respond to, that would be the best way we can still learn about a patient's journey with sepsis and still identify areas where quality of care needs to be improved.
Oh, thank you so much for reinforcing the importance of patient engagement, patient feedback. As they say, nothing for the patient without the patient. Thank you very much indeed for that. I'm now going to see if we can get back to Afrah. If the technical issue has been sorted out. I see Afrah, and great, she's with us. Right.
Yeah.
So
Thank you
Afrah,
so much.
you're
Do you
very
hear me?
welcome. Yes,
Yeah.
we hear you. Please do
I share my screen. Do you see my
yes.
screen? Thank you so much, Elena, and thank you for this opportunity to give me that to talk about Yemen, Yemeni women situation within the current situation, the protracted war that's happening currently. If you are, watching to my screen, is it okay?
Yes, we can see your screen. We can see your
Thank you so
screen.
much. Thank you. So I will start with the maternal newborn sepsis that we call it the silent killer in Yemen. So I'm going to give a background about the deepening humanitarian crisis in Yemen. So we know that the 22.3 million of people in Yemen, nearly 2/3 of the population required humanitarian assistance and protection services. 18.3 million, over half of the population, that are acutely food insecure, making Yemen the third most food insecure country globally. And 14.4%, the crisis worsening humanitarian need have risen by the 14.4, the percent of, the compare in 2025, reflecting the cumulative impact of conflict, economic collapse, and weakening institution. So this is the protracted, situation, war situation that happening since 10 years in Yemen. Women and girls are the epicenter of the suffering of this from this humanitarian setting. We know that the report that registered 10.95 million of those in need are women and girls facing high need, risk of violence, exploitation, and exclusion from essential services. 1 million pregnant and breastfeeding women are malnourished, threatening their health and that of their children. Women and girls are facing a compound, protection risk due to displacement, economic hardship, and limited access to diagnostic and healthcare. Gender-based violence remain a pervasive, exacerbated by the insecurity, displacement, and erosion of the social protection. Displacement and the protection risk in Yemen, 5.2 million Yemen host like internally displaced people, making the fifth largest internal displacement crisis in the world. Displacement women and girls face increased exposure to violence, lack of shelter, barrier to the access in reproductive health and protection services. migrant refugees and marginalized groups, such as we call them in Yemen, Muhammadin, which are part of those marginalized people, continue facing overlapping vulnerability and limited access to the legal social support. The collapse of the essential services. We know in 2024 that Yemen, especially UNFPA, that the impact of the PHA defunding, which make a big crisis for our support on within the reproductive health services at all level health facility and community level. 60% of these UNFPA humanitarian program in 2024 was funded by PHA, supported 24 health facilities, 16 women safe space, mental health service center, and 40 mobile RH and protection team to reach those most vulnerable women and girls in the most remote and undeserved area. So 1.4 million women and girls in Yemen lost life-saving services, having determined that impact on their health, safety, and well-being. About 1 million women lost access to reproductive health services. Nearly 300,000 women lost access to GBV mitigation and prevention services. More than 220,000 people displaced by conflict or natural disaster lost accesses to life-saving emergency relief provided through the UNFPA lead, we call it like RRM, the Rapid Response Mechanism. I think the donor is currently who are existed, and thankful for them that supporting Yemen still. The European Union humanitarian aid, the Iceland, Japan, and Kingdom of Netherlands, as well as Norway. Those are the only who are continue supporting within the services for maternal and women and girls services. When we go to the percentage of 59.3% of health facilities are fully functional, leaving millions without access to basic health care. 63% of Yemen carries, the highest cholera burden globally, while vaccination coverage remain just like 63%, which is, deteriorated before, was better that before the war started. Nearly 11.7 million school-aged children are deprived of education, with over 2,300 schools damaged and destroyed and repurposed, using for another purpose. The collapse of essential services and gendered impact. The 59.3% of health facilities fully functioning in Yemen continue carry the third highest cholera burden globally. Women and girls bear primary burden water collection and unpaid care worker, expose them to the heightened risk and to prolonged power outage of water and scarcity, which this is also affecting their life and their seeking for the services that they need for the reproductive or protection services. The education crisis also affected mostly the girls, and the food insecurity, economic collapse have forced households into negative coping. Especially women are suffering from 25% of them are with the anemia and malnutrition. The indicators that shows in Yemen, which is the maternal mortality ratio, still is high. This is published as estimates in 183 per 1,000 leave birth. But recently, World Bank, estimate another estimation with 118 per 100,000 leave birth in 2023. But still, we don't have that exact number of the maternal mortality and morbidity in Yemen as a national data or survey. The total fertility rate is 4.5. That children, 4.5 children per woman. 60% adolescent birth rate, and early marriage 32%. The family planning is for 24% contraceptive prevalence rate, modern and traditional contraceptive use. 33% of unmet need of family planning. These are also another indicators which are for Yemen, like the antenatal care coverage, 60%, which is almost like in the rural urban area. The recommended visit for more than 4 visits, also like 45%. Delivery per birth attendance, still we have skilled birth attendants are low, like 53%, and the delivery at birth is institutional delivery, 42%. Postnatal care is the critical gap that we are facing in Yemen. The postnatal of mothers within 48 hours, only 35% nation coverage. Obstetric care access also less than 20% at the facility level, that are especially now is reducing more because of the fund gapping that we are facing. The purpura sepsis in Yemen, that the third leading cause of maternal mortality, of course, in all the globally, but Yemen also we are, estimating or seeing that it will be more or worse than what we are expecting because we don't have national data. So 12 to 15% mortality contribution responsible for 12% to 15% of all maternal death. Why sepsis remain a major threat in Yemen? The high home delivery rate. We know the context of Yemen. It's very difficult context. Women cannot go alone to the facility. First, because of the cultural aspect that mahram should be there with her husband or brother or anyone should join her. This is first. The second thing is because of the economic situation that it's not affordable for the services, unavailability of females health workers, that culturally that women prefer a woman to seek for the services for the provision of the maternal health services. So the low PNC coverage, 35%, which is very low. Most sepsis cases identified too late due to lack of early postnatal checks within the danger window. 47% also the unskilled attendants. Most of the women delivered at home without skilled birth attendants, without qualified either midwife or nurse that can handle this prevention of infection. The compounding factors, that the maternal anemia, as I mentioned, that 25%, and the poor wash and infrastructure that we have, especially within the displaced women due to the war and the displacement that's happening. The strategic framework for the sepsis, that the national standard, Yemen ensured that the sepsis control is integrated into the national reproductive health, maternal newborn health strategy and midwifery strategies. So recently we reviewed and developed a national strategy for the reproductive maternal newborn as well as for midwifery strategy, ensuring that the infection prevention and sepsis is one of the important areas that we need to work on it. With the Ministry of Health and the sister agency that we supported to the government, the two ministries. The prevention, UNFPA ensure the sepsis control integrated to the national strategy, as well as the prevention, early detection, the danger sign, management, sepsis fund, active management of the third stage. So all these are are in the strategy is reflected, and the guidelines that developed for the health workers and nurses for the EMOC health workers. The comprehensive response, that the strategic leadership, the system strengthening, the equipping the comprehensive and basic emergency obstetric care, the EMOC facilities, with sterilization tools and life-saving RH medicine, RH kits, including the CDK, the clean delivery kits we are providing for the individual pregnant women, with the education, guidelines that included within this health, the clean delivery kits. The capacity building, that financing basic and refreshing training on job training for those health providers, health workers, and community-based maternal care, that community midwives that we have them are existed at the country level. The community impact, that supported midwives with home-based clinic. This is a Yemen. Recently we started after the war that to support the home-based clinic for those new graduated midwife and unemployed midwife. After the war started, almost like 10 years, the most of the health workers are not receiving the government salary. So in the absence of this government salary, UNFPA supported those midwives to continue practicing their, study where they studied. So we support them as a pre-service training as a midwife, and then to give them an opportunity to have their income generation, support themselves within establishing a small home-based clinic to provide with clean delivery for those women who prefer to go to community level, and then refer them if there is any complicated cases. The recommendation and way forward that we are working on the expand the postnatal surveillance, scaling up the postnatal care visit to ensure every mother is screened for sepsis within the first 48 hours. Strengthen supply chain, ensuring the uninterrupted supply of sepsis kits, including the antibiotics and sterilization tool, to the district level. Most of the time that there is shortage at the district level, and sometimes at the community level, even the midwives, they don't have those sterilization tools related to prevention of the sepsis. Midwifery empowerment, increasing the number of supported community midwives to bridge the urban to rural gaps. There is gap between rural and urban in the distribution of those community midwives. Community education, enhancing awareness on identifying the early danger sign and promoting hygiene practices among female. So we are using this practice, the safe delivery application we started as a pilot in one governorate with Health Institute teaching staff to let them teach the students that how to use this application, which is developed by Maternal Foundation based on latest global WHO guideline, adopted to national setting and national language, which it has more than 30 languages globally. But we adopted to the national Arabic language. It's free and works offline, doesn't need any internet, simple initiatives and engaging animated instruction, personalized game-filled learn, research remote healthcare workers. It helps anyone from those who are in a very rural area to learn, and a self-learning program. It can be found in the global Play Store also. So we go to the published Yemen study with the maternal sepsis data. We have two facilities that in one biggest governorate with big population size, a 7 years retrospective during conflict called Jibla Hospital, which is based in Eb City. 52 maternal deaths out of those 2,083 admission that happened during this period. And out of them, 32.7% was maternal death due to bleeding and 25% of eclampsia. However, sepsis was present at that time, but not broken out as top causes. The key barrier also, the 76.9 delay seeking care and delay in reaching facilities. This is, we know the three delays and the context of the Yemeni, the geographical population scattering. There is a lot of, risk that affecting the woman to reach the facility, plus the current funding and unaffordable the economic situation and of the woman and the girls even to seek for the services with fund. The health education study, and this was another study done in another southeastern governorate called Laht. They found that maternal health services underutilized because of the barrier is lack of female doctors and equipment. Medicine cost is high. So that's why there is one project is entered at this area, which called the voucher scheme, which helped to remove this financial barrier. The neonatal sepsis, we have one of the biggest and largest referral hospital called Athora Hospital, which is based in Sana'a. 57% is culturally positive causes of this neonatal, and 97.8% gram-negative, 27.8% mortality rate. The key finding, Klebsiella pneumonia, 36.7%, Pseudomonas, 30%, Pichypsia, and predominant in 2020 multi-center study, higher risk with vaginal delivery and home-based delivery without skill. So this is the risk that affecting the woman and newborns from the sepsis. The status include in Yemen, we have global burden, disease like other countries. I will pass this because Yemen is not part of this study. So they didn't include it. Yemen was not included. The Ministry of Health that we have, how we can access for the report from the Ministry of Health, as we are challenging that there is no public of Yemen Ministry of Health website with downloadable material, maternal sepsis reports right now. There is no any national data was done. The collective split of Ministry of Health that we have South and North Ministry, and also this affected the country. UNFPA situation in 2024-25 shows that only one facility out of 5 is functioning, and every 2 hours a childbirth from preventable causes. A woman died because of preventable cause, because of delivery. 1.43 million pregnant breastfeeding women needs acute malnutrition treatment in 2025. More than 40% of health facilities, non-operations. So this is the last slide. Sorry for my presentation. This is the general clinical outcome of this sepsis happening for the woman on the postpartum infection. That what is this? Why severe bacterial infection, mother's post-childbirth, leading to cause to maternal death within the first week or 5 weeks, occurring within the 6 weeks, 42 days. So the causes and risk factor that we all knows about it as a medical doctor, and symptoms, the complication, diagnosis, and treatment. So UNFPA is investing on community midwives, that we are expanding our work through the midwives to at least prevent this, preventable infection to be happen at the community level, and to refer those women in need to the facilities. Thank you.
Thank you so much, Afrah. You know, those are very sobering statistics, bringing to light the additional layer when we are in a conflict situation, as you have so graphically described in Yemen. We do have a question regarding home-based midwives, and asking if they are in a position to collect data and follow patients for the post-sepsis sequelae.
Okay, I will stop the sharing. Yes, we are trying to collect data through those midwives. However, it still needs, to strengthen this part of the data collection. Recently, we started to add them within our RH dashboard, that we add those midwife who we established for them, the home-based clinic, because we included the government Ministry of Health to be monitored at the governor at the district level. It is very difficult to monitor those midwives from their home. They are very, Yemen geographical is very, very difficult, mountainous and scattered population. So they need to be monitored by the government, from the Ministry of Health, to monitor their work and then to get the report from them. So we are now working on this part, to strengthen this part. Thank you.
Thank you so much, Afrah. I will now turn over to our next speaker, who is Hans-Jörg Lang. Hans-Jörg will be talking to us about the preparation to provide care in humanitarian crises to ensure best outcomes. Hans-Jörg is a pediatrician and pediatric intensive care specialist with over 20 years of experience working at the intersection of clinical care, global health, and humanitarian response. Hans-Jörg has contributed to several WHO technical working groups and involved in training and simulation exercises for filovirus outbreak contexts, with a particular focus on pediatric care. He has also contributed to the 2026 review of the Pediatric Surviving Sepsis Campaign Guidelines, and is associated with the World Federation of Pediatric Intensive and Critical Care Society. Hans-Jörg, over to you, please.
Yeah, thank you very much for the invitation to this meeting. So thanks for the organizers, and thanks for the participants who still stay online. So I will, in the next few minutes, try to give an overview on preparation to provide care in humanitarian crisis. I will focus on filovirus epidemics, but may give a quick link to conflicts and climate change related events. I would like to acknowledge colleagues with whom I worked and discussed over the last few years. So, as we discussed previously, child mortality decreased considerably over the last 30 years, showing what international collaboration can achieve. However, there are large regional differences, and especially countries exposed to conflict and humanitarian crisis still are facing high child and mortality rates. Essential pediatric care during health emergencies, that's complex. However, WHO defines essential standards for national and international emergency medical teams acting during different health emergencies, including natural disasters, conflicts, epidemics. Overall, it's important to strengthen national surveillance systems and emergency response capacity as part of strengthening resilient health systems. Humanitarian partnerships are crucial, obviously collaborating with national health systems and alongside United Nations agencies, the work of humanitarian organizations such as Médecins Sans Frontières, Oxfam, etc., is important. Maybe a quick comment in an example of an ongoing conflict. While we are speaking, widespread attacks on civilians continue across Sudan. There's unbearable related sexual violence reported. Children are exposed to killing, trauma, family separation, and displacement. Collapse of essential services, as reported from Yemen, occurred, and even health facilities have been attacked. Essential pediatric newborn reproductive health services are severely disrupted. Disease outbreaks are rising. And this obviously has drastic health consequences now and in the long term. A large part of the population is displaced, either internally or crossing borders to neighboring countries. A large part of the population faces food insecurity and depend on food assistance, emergency healthcare, shelter, wash services. Humanitarian funding remains critically insufficient at this stage. So the solution, I guess, for these problems is to stop attacking children and civilians. A few examples to climate change related events and impact on health. Climate change related events can have complex impacts on health directly or by impacting on infrastructure, health facility, agricultural production. To mitigate this, we need adaptation plans. These plans are associated with resource requirements and they need time. Climate change-related events can also impact on prevalence of vector-borne diseases and other infectious diseases. Again, to respond to this, we need adaptation plans of public health measures and health system strengthening, which needs funding. WHO suggests the development of national climate adaptation policies. And this ideally should include specific measures to meet needs of children. So just a quick overview. In the next few minutes, I would like to give a further example of an health emergency. Ebola virus epidemic response based on some experiences from DR Congo, West Africa, Uganda, and Equatorial Guinea. Several Ebola virus disease epidemics have been reported since 1976. A large outbreak, as you know, happened in 2014-16 in West Africa. Another large outbreak in Congo, 2018 to 20. There were various smaller outbreaks. And we also had Marburg virus outbreaks. But let's focus on Ebola virus disease at this stage. It is important in the development of resilient health systems to prepare for epidemic responses. This is important to protect patients directly, their families and communities, but also to prevent disruption of social and economic processes. Health systems ideally should be prepared to strengthen community and health facility-based surveillance, being able to provide this first care for patients with suspected high-consequence infectious diseases, and then notify and call for national and international assistance. Two examples of Ebola virus outbreaks. One in Eastern Congo between 2018 and 20. The epidemic response in this case was undermined by conflict and insecurity, the presence of armed groups in the provinces affected in Eastern Congo, North Kivu, and Ituri. The overall case fatality rate was high, but importantly, despite all the challenges, patients who had a chance to be treated in treatment centers at an early stage of the disease process had better survival chances. Another example, a recent outbreak, Ebola virus disease, smaller in scale and duration in Bulapé, Kasai province in Congo. Important here to note that most likely the first spillover from the reservoir and first human infection occurred in August 2025, but only 2 to 3 weeks later, the outbreak was noticed and notified to national health authorities and the international community, highlighting again that preparation for epidemic surveillance and response is important as part of a resilient health system. What is Ebola virus disease? Well, we can call it also a sepsis syndrome. Host-pathogen interaction, a complex immune response. Initial symptoms are non-specific and actually hemorrhage occurs late. So the term viral hemorrhagic fever, at least at the beginning, can be misleading. Many patients develop multi-organ dysfunction and overall case fatality rate can be high. However, if patients can access essential emergency and critical care and specific therapeutics at an early stage, survival rates above 80% have been reported. And this is also true in children, some unpublished data, children who come early in their disease process with no organ dysfunction and low viral load have higher survival chances as patients coming on arrival with multi-organ dysfunction. We need comprehensive outbreak responses. Multidisciplinary teams and communities are at the center of the attention and play obviously a crucial role. We need logistics support, supply chains. We need epidemiology and laboratory to organize active case finding, follow-up of contacts and testing. And we obviously need the clinical teams. So, care of patients, but also infection prevention control programs, organization of safe and dignified burials, and important for Zaire Ebola virus, we now also have vaccination programs. Important during health emergencies and often slightly neglected is the support of the regular health system, as important as the care of patients affected directly by the epidemic. What happened in Kasai DRC in terms of setup of treatment centers? An initial treatment center was set up in Bulapé, the center of the zone de santé, the district, and then satellite treatment centers were set up subsequently. That decentralized outbreak response approach is crucial to allow communities to access care as quickly as possible. The initial treatment center in Bulapé was suboptimal and took over part of the district hospital, and that obviously then has a negative impact on the regular health system. And also the configuration was challenging of that treatment center. Case fatality was high. However, patients receiving treatment in treatment centers with supportive care and specific therapeutics, 60% of these patients survived. Outbreak response measures improved over time and were becoming better as time was going on. Important, WHO and WFP with partners, the MOH obviously and MSF, were able to set up a treatment center within 2.5 weeks. I think that was a big success. This was tested beforehand, and it's important to notice that WHO and WFP has an initiative called Initiate 2, which led to the design of optimized configuration of treatment centers. Different agencies and partners worked together, humanitarian organizations, but also a multidisciplinary approach was used, working with clinicians, psychologists, technicians, engineers, and architects. And I think that interplay is absolutely crucial to respond to epidemics, but also to improve regular health systems. The treatment design of treatment units is crucial to provide essential care with empathy and humanity, and this is particularly important for children. And the key design principle must be in the future, treatment centers need to allow visibility of patients from a low-risk zone. That allows better patient care, better surveillance, better psychological support, and also parents, relatives can come and visit and see what's happening. That improves also community acceptance. Obviously, more details are available. You can contact me and I can link you with WHO Technic team to get more details on treatment unit design. It's important, the preparation is crucial in terms of response strategy, treatment unit setup, but also in terms of supply chains. And if we want to provide good care for children and pregnant women, we need to play a role in all these different domains. How can care for these patients with Ebola virus disease look like? Well, we actually use pretty much indirect evidence from sepsis care. So we more or less have the same strategy, the same approach. And depending on the context, we can define essential standards of care, but that should at least include oxygen provision, the possibility to give fluids safely, to have access to blood transfusions, and that can be challenging in epidemic contexts, treating neuro emergencies, fluid management, and so forth. Also, the treatment of bacterial co-infections, malaria is important. And then obviously, timely prompt administration of Ebola-specific monoclonal antibodies as early as possible. These specific therapeutics are now licensed for auto-Ebola virus Syrense, but not yet licensed for Sudan Ebola virus or Marburg virus. However, there are candidates available, and here important again, the WHO as a focal point to coordinate setup of clinical trial protocols, SOPs, and ethical standards for the use of experimental therapeutics.
Thank you.
Closely coming to an end, I want to highlight again the importance to prepare for the care of children and also for pregnant women, including completion of antenatal care in these treatment centers, childbirth, postpartum care, care of obstetric emergencies, newborn resuscitation, and so forth. We need to look after patients after discharge, patients with confirmed and non-confirmed illness. Family rehabilitation centers are important to care for children whose parents have been hospitalized, but also for the care of patients who are discharged and waiting for resettlement. And many of these patients need a time of rehabilitation, and their resettlement needs to be organized. Comprehensive support of Ebola virus disease survivors is important in terms of psychological support and medical support. Important also that Ebola virus can persist in the semen of men and in utero of pregnant women and in maternal milk, and this needs to be addressed. But we need more support also for families and communities affected by epidemic events, and this means support of regular health services, support of communities is crucial. So, and here I come to an end. And if there's one last little 10 seconds, I want to highlight again the preparation. This can be done by international organizations, but I want to highlight a remarkable project organized by the Joseph Kissoon University in Ouagadougou, Burkina Faso. They have set up a diplôme interuniversitaire for epidemic preparedness, and that includes also a practical phase where we conduct complex simulations to prepare for epidemic responses. Thank you very much for your attention.
Thank you, Hans-Jörg. Because time is not in our favor this evening, I'll move on very quickly to our fourth speaker, Mohammed Elfatih Ahmed. Mohammed is a leading voice in internal medicine, critical care, and healthcare transformation. And as vice president of the Sudanese Sepsis Alliance, he champions sepsis awareness and care improvement regionally and globally. Over to you, please, Mohammed.
Hi, everyone, ladies and gentlemen, and my distinguished colleagues, respected colleagues. Today, really, I'm not gathered merely to discuss just a presentation. Really, I want to reflect a story of courage, resilience, innovation, and humanity under very extraordinary situation in Sudan. A story for newborn lives protected in the middle of war, in the middle of chaos. A story of collapsing system did not defeat determination. To understand or to understood saving life is not merely need an expensive technology. And that's what I want to challenge this assumption in this presentation. There is a low cost evidence-based interventions even can save newborn. What I want to say, this presentation reflecting a simple intervention that saves lives, and actually is one of many initiatives under the name of SKY, Sudan Clinical Audit Initiatives. And from the name SKY, the limit is SKY for our projects. And this is one of our projects. So welcome to the story of impact, and welcome for a story for resilience through this presentation, and welcome for a story life saves through it. So what I want to say, if you want to save a newborn from sepsis in a collapsing health system, you must use advanced tool. Here I mean not the incubator. Here I mean not the incubator. I mean clean towel. A mother warms through her skin to skin with her baby, and the early drops of the breastfeeding for the child, plus checklist and system to put to check the quality on the middle of chaos. So in a fragile system, biology, here I mean the skin to skin contact, and the breast milk drop is that matter at the end. And I will make more emphasis on that. So unfortunately, 2.7 million neonatal deaths occur worldwide annually, and primarily in the first week of life. And in a resource-constrained environment, suboptimal newborn care is driven by service shortages, and even because outdated protocol and limited awareness and educations. However, the major causing of deaths are preventable We just need to use evidence-based care package. That's what I want to display on this presentation. And what does war did in newborn care actually is transform their vulnerability into mortality. And the hidden killer is the cold baby. I mean here, the cold stress. When the baby born and not making the bundle that I will explain in the next slides, these bundles, which is a very simple approach just to make skin to skin for the baby, this will stop the cold stress that happened to the baby, which is increased oxygen consumption, which may lead to hypoglycemia, which may lead to metabolic acidosis and even respiratory compromise and even immune suppression. So a cold baby becomes a vulnerable host for infection. With a simple skin-to-skin care is a precision physiology, is acting like advanced incubator, is just a mother chest, because it maintains temperature for the baby, it stabilizes his heart rate, it supports his respiration, it reduces even his stress hormone, and even conserve his metabolic energy and enhance bonding, which is that matter at the end. So in a simple way, the mother's baby acts as a living incubator. And even the colostrum, which is part of the milk of the breastfeeding, is just like an immune engineering, because it secretes IgA antibodies and it contains antimicrobial peptides, leukocytes, nutrients, and even give gut protection barriers and even microbiome support. So colostrum, which is in the breast milk, is just the first vaccine for the baby. It seals border before pathogen invade. Unfortunately, nearly half of under 5 deaths occur in the first neonatal period. And those because of staff shortage, weak postnatal follow-up, supply disruption, poor referral system, and even overcrowding. So sepsis remains the major preventable cause of newborn mortality. In fragile and humanitarian setting, interruption in maternity care multiply infection-related death. And here is just an organogram for the things that make the leak when we want to provide optimum care of newborn. If those happen, definitely the care will be suboptimal. Here I mean delay newborn assessment, lack of essential supplies, inadequate thermal care, delayed breastfeeding, and poor infection prevention system. All of those factors is just like a leaks in the system, and that's why we hold this quality improving projects to seal these leaks, to fill these gaps, and even to redesign the system by making an intervention, and I will talk about this intervention later. So it's simply, we use a clinical audit. We're looking for the evidence-based standard, which is the WHO immediate newborn care guidance. And we use the audit cycle as a 4-week audit cycle in one of hospitals in Sudan named Afrah Teaching Hospital. And we just make data collection through structured audit checklist and direct observation, and then we're making analysis. And we assess the domains that mentioned by the WHO immediate newborn guidelines. And the objective that we hold is to measure compliance with essential care, to detect system gaps and perform root cause analysis, and to recommend corrective action to fill the gaps and to establish a continuous quality improvement. And those are the standards. In a very simple, at pairs, we should make immediate drying, breathing assessment, gentle stimulation if ethnic and delay cold clamping. In the first hour, we should make the skin-to-skin care, breastfeeding, initiation, vitamin K administration. Before discharge, we should look and educate the mother about the danger sign as a screening tool if anything happened to come back, and to provide vaccination and to counsel the maternal and to educate her and to know the postnatal review plan. So it's just a simple intervention, but with extraordinary impact. Those are the WHO standards, the golden minutes from 0 to 3 minutes. We should make in the immediate drying, assess spontaneous breathing, and suction only if meconium is stained or the baby is not breathing, and then to delay clamping in the first 1 to 3 minutes. And then the golden hour from 0 to 60 minutes, immediate skin-to-skin contact, initiation of exclusive breastfeeding, and giving vitamin K injection. And the first 24 hours and beyond to delay bathing for more than 24 hours and keep the baby warm, and immunization to prepare the child for immunization, BCG, Hep B, and oral polio here in Sudan, and to identify and treat preterm low birth weight immediately and counsel the mother for the postnatal contacts and the danger signs prior to 24 hours to minimize any infection that may arise and to act as rapid as we can. So simply a benchmark that we want to reach. We want to be 100% adherent to those WHO immediate newborn care bundle. Then we make our cycle for data collection and then data analysis. And our goal is not simply to record the data, but identify exactly where the gaps is and to provide, based on those gaps, to put our action plans. Here is the gaps that we figure out during our analysis. And as I mentioned, that we want to reach the 100% targets. And it's obvious that the problem was in the initiation of exclusive breastfeeding and in the immunization, and even in identifying preterm low birth weight immediately, and even in the counsel for the 3 postnatal contacts and danger sign. These are the red lines is the areas that we want to work on to connect and to link to being adherent for the whole package of the WHO neonatal care. And if actually every missed step is represent a lost opportunity for neonatal sepsis prevention, and instead of blaming our staff, we should ask, how is the system designing failure? And that's why we use the root cause analysis. We use this Ishihara frame to know where the system gaps is. And then when we know the gaps, we redesign the structure, redesign the process for the optimal outcome. And here is the finding that we find from our root cause analysis based on managerial factor, material factor, people factor, process factor, environmental factor, and even patient factors. So the environmental most probably is the suboptimal physical facility infrastructure. There is a problem in the infrastructure, and even there is a cultural belief impacting the care of norm. I mean here the delay bathing and the early breastfeeding, and equipment, insufficient access to critical supplies like warming equipments, and the service shortage and lack of skilled personnel on shift, and limited awareness about the updated WHO protocol. So it's just like the cheesecake or the Swiss cheesecake. There is a holes that we need to identify and then to be filled. So a single misstep is vulnerability, and when multiple system layer fails simultaneously in humanitarian crisis, the trajectory toward neonatal sepsis become unobstructed. And here are the action plans that me and the team we put it together to deploy standardized newborn sepsis prevention bundle, and to implement mandatory delivery room checklist is acting like just a memory check for us, because the cognitive load of work sometimes it will affect the process of thinking. So it's just like a memory aids. And then we already conduct staff refreshing training, and we establish dedicated breastfeeding support pathways, and we enforce mandatory danger sign counseling for the mother. Those are the level of the persons. At the level of the system, we looking for monthly continuous audit cycle, and to create dashboards for quality indicators about the things that we want to achieve, and to strengthen vaccine access protocols, and to improve documentation and tracking system, and to establish transparent leadership accountability. So here are the actions that we did in a time matter, because we all know sepsis is time matter. So we start immediate to let the people in the service to start immediate drying and back rubbing in 2 to 3 times, and perform within 30 to 60 minutes before cold clamping. And the cold clamping should be delayed for 1 to 3 minutes. And the suction is only indicated if neonates have some sort of meconium stained, or he coughing, or he needs some sort of support for his breathing. On the other golden hours, we're starting to the skin-to-skin contact within the first hour to prevent hypothermia. As I mentioned, the consequences of this hypothermia, the cold stress I mentioned earlier, and to promote feeding. And then to initiate exclusive breastfeeding standard dedicated exclusively for breastfeeding until 6 months, and to provide prophylaxis with vitamin K, 1 gram intramuscular, to prevent hemorrhagic disease. And unfortunately, any failure of these 3 notes significantly increases the vulnerability of the newborn on the following days. On the first 24 hours, the passing delayed until after 24 hours, and the immunization should be given within the 24 hours, and immediate identification and specialized care for preterm or low-term babies, and minimum 24-hour facility to be stay completed, and then the assessment for danger signs should be performed, and mother counseled about those signs, and finally, and most importantly, to complete documentation for all intervention that done in the file. Actually, quality improvement is not a luxury during crisis. It's a survival, literally it's a survival strategy. And it's all about doing the right thing in the right way, in the right time, for the right person to have the right result. So clinical audit is not a single event, it's a systematic, continuous, and is most importantly is a culture of improvements. And when we apply those interventions, we bridge the gap between the practice and the reality and the standard. And we're looking for standardizing the clinical practice through focus on protocol and monitoring, and to empowering people. And that's what we do, is making the powerless powerful, and making them really leaders for making those interventions, not just the clinical part, even beyond their clinical part, to be like a lifesavers for the system through diagnosing the areas that need intervention, and making management for the system as they diagnose and manage their patients. And lastly is to upgrading the environments, focusing on the resources and infrastructure. With this, filling these gaps, and definitely we need to re-audit, because we believe that every newborn deserves a flawless first 24 hours. And actually, every birth is a sepsis prevention opportunity. And universal sepsis care begins in the first hour of life. It's just all about looking for the standard, which is evidence-based essential care, the WHO guidelines, and then to continue the clinical audit cycles. And most importantly, the shift the balance of power, making the powerless powerful, staff empowerment, and maternal educations. And before I end, really, I want to salute all the heroes behind this mission, because behind every life saved, every newborn protected, every mother comforted, and every moment of hope restored in the midst of this war and this crisis, those heroes stand as a team of extraordinary individual who's dedicated to rise above really very challenging environments. And those are the team, really, they represent the unseen strengths and the unseen steady hands behind this success. And really, their success is beyond the report. It's not just about data report. They saving newborns, they making their mothers returns home and their families to bound together. And those, the names, Khalid, Marwa, Mohammed, Ja'far, Iyas, Sibyan, Muaz, Iyas, really they become the light, the light on the darkness of the war. And as I mentioned in the last conference, Sudan will never die. And we believe that Sudan will rise with its people. Sudan will breathe with its healers, and hope is always there. And at the end, really, I want to thank those heroes, to thank the Global Sepsis Alliance for making this opportunity for Sudan Sepsis Alliance to represent and to tell these stories. And again, thank you for Professor Kamal Osman, the president of Sudan Sepsis Alliance, the one who is behind this success. And finally, thank you for the heroes who did these projects. The impact of their work will live beyond today. Thank you.
Thank you so much, Mohammed. Indeed. Thank you to all our heroes and heroines. Thank you to our erudite speakers today. We started with Yami. Thank you, Yami. Afrah. Thank you, Hans-Jörg. Thank you, Mohammed. It is now left for me to turn over for closing remarks to the president of the Global Sepsis Alliance and past president of the World Federation of Pediatric Critical and Intensive Care Societies. Niranjan Tex Kissoon. Over to you, Tex, to close us out this evening.
Okay, thank you very much, Eleanor. And another meeting has come to its end. This is the 6th Congress meeting, and it has been highly successful. We've had many wonderful speakers from various parts of the world. We've had an audience of over 8,000 registrants from many countries. And this meeting is truly a global effort. There are many people I'd like to thank. I'd like to thank all the speakers for their contributions to this. Without them, it would never happen. I'd also like to thank all the moderators who has done a very wonderful job in keeping this Congress within time limits. I'd also like to thank our sponsors, Biomeru, Menarini, and Sobi, for the generous support. And were it not for their support, obviously, we would not be able to bring this to fruition. We also have to thank our backroom supports, who has had this meeting running very well, the team at NC3, and also the small but very powerful team that we have in our office. There are a few individuals there. You can see Marvin on the screen, but it's a very powerful group, and they have dedicated and gone beyond a call of duty over the last few months to bring this meeting to where it is. And as I close today, I would like to leave the message that should just be the beginning. I think that when we look forward to the 2030 agenda, I would like to say that one of the big facets of it, it's a whole society sort of project. Everyone should be involved, and I hope you will go back to your places of work, your countries, or wherever you are, and encourage others to join in this mass movement. So on behalf of the Global Sepsis Alliance and our board of directors, our supporters, our executive, and our regional alliances across the world, I'd like to say thank you. Good morning, good evening, good night, wherever you are. And we look forward to your continued involvement going forward. Thank you. Bye.